Hello everyone, my name is Chris Harrop, Senior Editorial Manager at MGMA. Welcome to today's session, Rethinking Metrics, Dashboards, and Appointments After COVID-19. We have a few reminders before we begin. You can claim ACMPE, ACHE, CME, and CEU credit. Attendees of the live session also can claim AAPC, CPE, and CNE credit. Claim continuing education credits starting next week using the MGMA CEU portal. For AAPC credit, the code will be emailed to you. Submit your questions, resources, and comments using the chat area. Slides and resources can be found in the lower left section of the previous session page. And with that, the education for this session will now begin. In today's session, Nate Moore, Chief Executive Officer of Moore Solutions Incorporated, will explore how practice leaders can set new operational benchmarks by identifying relevant metrics with data from their practice's existing systems, all to ensure financial viability through the pandemic. Nate, I know you've got a lot of great information to share, so I'll turn it over to you.
Good morning, everybody. Thanks for joining me today. Let's see if I can convince my video to go on. There we go. And last piece of the puzzle. Here we go. Welcome. Good morning. Thanks for joining me today. For those of you who have heard me speak before, welcome back. For those of you who have not heard me before, my name is Nate Moore. I'm a CPA, MBA, fellow in the American College of Medical Practice Executives. I'm the data guy. And the short version of the story is, if you can report like what I'm going to show you today, you can dress like this. And everywhere I go, I wear an Aloha shirt. So I got an Aloha shirt on today, even though I live in Utah. What I want to do today is something a bit different than what you're maybe used to as we go through these this virtual conference. They're the learning objectives, but this is live. I'm going to adjust my presentation based on the comments that are in the chat window. Hopefully I've got the chat window up and going and I'm doing it through the Zoom webinar. So I'm looking at that chat primarily as opposed to the hub one. And so please feel free to send comments and ideas here. And I'm going to modify this presentation based on what we're talking about. So please, the participation is what's going to make this go and what I think will make it interesting. You've read the learning objectives. I'm not going to spend any more time on that. So pandemic, right? We're stuck at home. I live in Utah. I'm about 4.5 hours from the Grand Canyon. I'm reading the sign. I'm about 4.5 hours from, I'm a little more than 4.5 hours from the Grand Canyon. I'm 4.5 hours from Yellowstone. That's where we're going with this. So I'm 4.5 hours from Yellowstone. So I want to show you a quick home movie that kind of explains my perspective on the pandemic to get started, then we'll get going. So this is the Grand Canyon in Yellowstone National Park, not in Arizona, but in Yellowstone National Park.
January 2020, February 2020, March 2020, April.
That's kind of how your year went. January and February 2020, everything's peaceful. You're just floating along and things are going. All of a sudden by April 2020, boy, we're off the cliff. And the problem and the reason we're talking today is once you go off the cliff in April, we're kind of still off the cliff in May, June, and July. Now, the beauty of this picture is at the very, very end, after all that turbulence at the bottom, it does get calm, at least for a while. And that's what I'm hoping for. If you're not familiar with MGMA Stat, the one thing you got to do after participating in this session, if you don't do anything else, is join MGMA Stat. What it is it's a free service. You don't even have to be a member of MGMA to join. And every Tuesday, they'll send out a text message-based poll question. So the question's brief, it's text message, right? And the answer, it's quick to answer. And then every Thursday, they'll send out a response and a graphic that looks like this with what's going on in healthcare. And especially in a year like this, where there's so much uncertainty and so many things going on, it's a great way to keep the pulse on what's going on in healthcare. So text the word Excel, like Microsoft Excel, to 33550. And MGMA Stat will send you an invite and you'll start getting these Tuesday questions and Thursday answers. It's a great way to get a sense for what's going on. So this is a question from August, and it said, are you changing your metrics, your KPIs in response to COVID-19? And about a third of the participants said yes. And that's kind of what I want to talk about today, is what I'm seeing folks do in terms of looking at metrics and what are we doing differently as a result of the pandemic. The other thing MGMA Stat did on this particular poll was they said, hey, you can add a comment at the end if you want. So again, text-based, it's brief, but you'll see people calculating percentage telehealth visits. I'm used to that. That makes sense. But others are looking at care graphs. Others are looking at tracking their weekly patient volume. And ER groups tracking RVU per patient. That's moving on them. Pre-registration per day, contactless payments, those kind of things. Some things you'd expect. Some of the other answers I thought were interesting. Some of them are adjusting for productivity by provider or billers. Others are looking at productivity in a different way. And another group said, we're just ignoring productivity. We've got so much going on that we're just backed up and we're not even looking at productivity. We're going to talk about productivity today and how you might think about getting your arms around productivity as a result of this lovely pandemic. Another poll from my friends at MGMA Stat. 55% of healthcare leaders say their organization's new patient volume's gone down. And it's a pretty significant gone down too. And so one of the things I want to start with is we have the big shutdown this spring. Heaven knows what this winter is going to bring between flu season and a second wave or a third wave, and depending on what part of the country you're in and all that. Let me show you what some of the groups I work with have been doing. One of the groups said, data mine our system and grab all of our canceled appointments. We want to make sure everything we had to cancel this spring, we're going to reschedule. And why did we cancel and when did we cancel and that kind of thing going on. For them, it was a big deal. This one as well. This is a group in the Southeast, and what they do is they're saying, and this is pre-pandemic, by the way, this is something they've been doing for a couple of years. What they're saying is, hey, we want every appointment that was canceled yesterday, because if it was canceled yesterday, that means there's an appointment slot and we can fill it. And so this email goes automatically to the triage department that handles, they centralize all their calls in the call center. And so they get this, and then I've mapped out like the provider's name and the facility and some of that information. But what they're trying to do is fill appointments. I think one of the big issues in the pandemic is if we're limiting appointments. I was talking to a group last week, and they're not doing double booking anymore because they're trying to socially distance in the lobby and that kind of thing. So they're limiting patient appointments. Or if you've slowed down your patient appointments, how do you prioritize those appointments? That's one of the things I want to talk about today. How do you make, okay, you got to prioritize them, and you got to make darn sure the last thing in the world you want to do. If revenue is down due to the pandemic, you don't want appointments to go unfilled, either because of no-shows or because we didn't recognize it was canceled, we didn't fill it fast enough. Same group does this. That same call center, that same triage gets, here are all the appointment slots that are available today and tomorrow. And again, I mapped out the provider and the location, those kind of things, to try to make darn sure that we fill those things. And Karina, thanks for sharing. We're making confirmation calls. We're going to talk about changes in the whole confirmation process as a result of COVID. This is what a group in the Southwest did. And obviously the dermatology, they're doing Mohs. If you're not familiar with Mohs, it's cancer treatment in dermatology. And so what they'll do is they're looking at no-shows and cancels without a future appointment. So it's one thing to no-show if you have acne. It's a different thing to no-show if you have cancer. And so what they do is, this is an automatic email that comes out every morning that says, here's folks that no-showed, here's folks that canceled. And they stay on this email until we take care of them and we make sure that their melanoma is treated. This same group, what they'll do when they look at available canceled appointments is they light up different colors, and they say, all right, this kind of appointment we're going to light up in yellow because it's more important to us. So this is in a special location we're looking for, we want to make sure we fill, or this just showed up on the email just today, and trying to kind of like conditional formatting in Excel, trying to light up parts of this automatic email so they can make sure that specific appointments get filled. Again, if revenue is down and appointments are at a premium, the last thing in the world I want to do is miss a surgical appointment or an opportunity to get a surgical appointment. We're going to talk more about that too. Let me throw the first question up here and just respond via chat. Are you seeing fewer established patient in-person visits? So they're established patients, right? But they're reluctant to come in as a result of COVID-19. Are you seeing that? John, my friend in Montana, said, yeah, he's seeing that. Richard says 50-50 split of in-person and telehealth visits due to COVID. Lots of people are seeing people, I'm seeing a couple of no's, but lots of people are saying, we're seeing fewer patients being willing to come in. And so again, I've got a limited pool of appointments, and I've got folks that don't necessarily want to come in. And so I'm trying to meld telehealth into this. How do I prioritize this mess and not let, like the most patients, not let, truly sick patients fall through the cracks, and not let my revenue go down terribly either. This is from a group that uses the Centricity product. And that's their practice management system. So we went into Centricity, we data mined and said, all right, let's go find rescheduled patients and what happened to those rescheduled patients. And then rescheduled surgeries is the other thing they're looking for, is if there was a surgery before the shutdown and it didn't happen, we want to make darn sure that surgery happens, especially if it's going to take a couple of weeks to get the new surgery pipeline going again and get new patients lined up for surgery, that kind of thing. Some of the things you might think about: do I need to do something to confirm patients differently? Some folks are banging on the door to come in, some won't come in. All kinds of good feedback here. Thank you for sharing. I think if you want to just listen to Nate talk, I do a weekly podcast. You can listen to Nate talk all you want, but the opportunities of these conferences is to interact with peers and see what other people are doing. This is great information here. Thanks for participating in the chat window. You may also need to think, what do I need to do differently in pre-auth? Do I need to figure out something differently in pre-auth to make sure pre-auths happen, or to keep my arms around pre-auth because it's such a moving target that I don't want something to fall through the cracks? I actually get a surgery, it's actually going to help my bottom line, and then I don't pre-auth it because it fell through the cracks. Some of the things you got to think about. This is the canceled surgery I was telling you about. And it was canceled before, and heaven help us that there's not another big shutdown. But how do I make sure that stuff that got canceled, procedures or ancillary or surgeries or whatever it is that was scheduled, doesn't fall through the cracks? I mean, part of it's a patient health issue, right? If they need the surgery before, they probably need the surgery now. But part of it's a revenue, keep us in business perspective to track those canceled surgeries. I want to throw another idea at you is we're trying not to lose what limited appointments may be out there. This is an idea a group in the Southwest had. And what they did, you're familiar with Claim Scrubber, where you throw all your claims into some testing mechanism, some tool to make sure that the claims aren't going to get denied by some stupid or something we could have fixed when they get through the clearinghouse and onto the payer, right? This is an appointment scrubber. So what I do is I scoop up all the outstanding appointments. I look out into the future and look as far out as you want to look. And here's every appointment I can find. And here are the problems I can see coming in the practice management system, that when Nate shows up for his appointment, we realize he's got the wrong insurance, or he's seeing the wrong provider, or we don't have the labs done, or I'm in a collection status or a hold status, or when I made the appointment, we took this insurance, now we don't take that insurance, those kind of things. So what we do is we teach the system all these rules. And then once we've got these rules in place, there's a morning email that says, here's all the upcoming appointments that are going to break that rule. And they stay on this email until you either fix the appointment, or the appointment passes, or we've got a mechanism to ignore it and say, yeah, this is okay, we'll let this person come in. But the idea is not to give up precious appointments slots to stupid things that you could have fixed if your practice management system had just told you that it was out there. And and I'm saying, Teresa, our primary practice has got pent-up demand. And how do we manage that pent-up demand? And Jennifer's saying, hey, our surgical specialists are feeling the decrease in patients. And how do we prioritize? We're going to talk about how to prioritize and find surgical business, right? Or ancillary business or whatever. Another question for our experts out here. And again, thanks for sharing. Have you changed your strategies or rearranged your patient schedules, your templates or whatever, to try to fill those limited appointment slots with surgery candidates or procedure candidates or ancillary business or whatever? Anybody done anything that way? Trish, to answer your question, I have not seen an off-the-shelf electronic resource to managers, the appointment scrubber. So we wrote it from scratch. And you could get your IT team to do the same. So look, find all our outstanding appointments. Here are rules that we can look for. An example of a rule is the dermatology practice I wrote this for initially said, our policy is we're not going to see minors, anybody under 18 without a parent present. So we could look out to the schedule. We know what your age is. If you're under 18, we could reach out and contact those patients and say, hey, our practice policy is, we're not going to treat minors without a patient or a parent there. So do it that way. Brian's saying we're open to more Saturday hours so we could accommodate and do more socially distance. Laura says we've got different tracks for respiratory or virtual or well patients to try to schedule them separately and help them do that kind of thing. Some of you are going to say, Nate, I don't change my templates for love or money, because as soon as you open that Pandora's box, physicians go crazy or whatever. But I think you might want to think about, particularly depending on how long this lovely pandemic goes, do I change my strategy for scheduling to make sure that I'm getting the patients I want to see? Another thing for my friends at MGMA staff, 1 in 4 healthcare leaders have seen their payer mix change thanks to COVID. So of that 26% that saw it change, no surprise here, where's the growth? Medicaid and self-pay. So the ability to collect and the ability to collect up front from those self-pay patients or whatever is going to be another part of the transition if your practice is like these practices and seeing something different going on in COVID. I want to show you a couple examples of some dashboards that are different based on COVID. So no surprise here, you're going to see telemeds on the dashboard now, the year-to-date average, and there's no prior year-to-date average over here. They weren't doing telemed before, so they're trying to track telemed. This is an orthopedic practice. And so they've got the provider here and the practice to compare it to down below. And one of the changes I'm seeing in my dashboards is they're doing things weekly instead of monthly. So you'll see it's last week, 2 weeks ago, rolling 4-week average. Same for the overall practice. They're looking at things weekly, not monthly now, because of the uncertainty in what's going on. This is a different practice. And so they're looking at the month, year over year, so same month last year, current month to date, average daily visits, and then they project out their month and where we're going to be by location and appointment type and whatever, and trying to get a projection based on this month's volumes. Where do we think we're going to end the month versus where we were a year ago, and trying to get their arms around it. And you'll see this is early in the month. This is one that came out August 4th. And so the projection's got a lot of room to move over the course of the month of August. But they're trying to get their arms around cash flow. Anybody added metrics or removed metrics from their dashboards as a result of COVID-19? And if you're willing, Trish says she is saying we are. Telehealth visit volumes, I believe that. Surgical booking volume and backlog. Great suggestion, Jennifer. Obviously, there's surgery practice. And where's our backlog? And do we need to, the last thing you want to do is lose OR time in this thing. Lots of people adding telehealth. A backlog is a big deal. And trying to get our arms around how do you define that backlog, and how do I measure that backlog? How do I get my arms around what's still out there waiting to come? Great suggestion. More transparent production benchmarks and weekly visit goals. Absolutely. Visits and work RVUs compared to revenue. If that's you, Cindy, that's a great suggestion. The ratio of video visits to in-person visits, and is that moving? Some of the groups I work with did telehealth when they kind of had to, and now we're moving back to in-person. And other groups are, no, telehealth's here to stay. We're gonna do this, and we're gonna try to get our arms around revenue loss. These are great suggestions. If you can't see the chat, Zoom likes to make it full screen. Exit full screen, and you'll be able to see the chat. And the great suggestions and the ability to interact. That's the reason to do this session live, is to get this interaction and the sense of what's going on around the country. You can't get it any other way. Let me throw an idea at you. Automating your dashboards doesn't just save you time. A lot of the groups I work with say, hey, this dashboard used to take me 2 days of, download these reports and cut and paste and clean up all the junk out of my practice management system and present it in a way. It doesn't just save you time to automate it. It lets you send the dashboard more often. And in times like this, that's a big deal. That's a big deal to be able to send the dashboard more often. And so I think if you don't have an automated dashboard, either through your practice management system or some other tool, or you're doing Excel or whatever, find a way to do it. What I do is I go straight to SQL Server where the data is. That's behind most of the major practice management systems, the NextGens, the Allscripts, the Centricities that are out there. Take the data straight from there, connect it to Excel or connect it to a dashboard tool or Power BI or whatever you're doing, and automate that dang thing so you can report more often in today's world. more of my practices than ever are putting costs on the dashboard. For example, one of the groups I work with uses Sage, and Sage is their accounting package, and Sage is based on SQL Server, and so it's their practice management system. So we take the practice management system, put that in SQL, we put Sage, put that in SQL. Now we got a data warehouse with both, and we can throw revenues and costs on the dashboard. And in today's environment, it's a big deal. Deep breath. A slide from back in May from our friends at MGMA Stat. Has your organization's provider comp been impacted by COVID-19? 82% said at least some of their providers had been impacted by COVID-19 in the bottom line. And 62% said every single one of our providers has been impacted by COVID-19. And so what we need to figure out is we got to remedy this. I mean, as practice managers, what do we do to help our providers recover some of this income? Brian, I don't know. MGMA, good question. I don't know who that 19% is who hasn't been impacted there. They didn't ask. MGMA Stat didn't ask. You know, like you say, who hasn't been impacted? It's only 82%, right? A couple of ideas. I want to skip past this question in the interest of time in terms of what are you measuring in response to COVID-19, because I want to show you a couple of things. This is from a neurosurgery group in the Southeast. And so what we did is we're trying to get our arms around what they call hit rate. So again, they're neurosurgery, so they're going to be different than a lot of you folks in that they've got a very long lead time, right? The conservative care and trying to get those pre-authorizations is it's a project in neurosurgery, right? Some of you neurosurgery folks out there can relate. So what we do is we go out to the practice management system and we're data mining to say, show me all the new patient visits between January 19 and July 19. So what the advantage of 2019 is you don't have the pandemic in the middle of it. So you can get some sense of normal, right? What was our hit rate like? And so for that 7-month period, I got my new patients, right? That's my bucket. And so then what they do is they look out from those 7 months and they look into the future and say, okay, of those new patients, how many got treated and when did they get treated? So surgery is our first question, right? It's neurosurgery. So what I've masked here is the providers so they can, you know, the neurosurgeons are competitive. I don't know if you're a neurosurgery group or you know any neurosurgeons, but neurosurgeons are competitive. So here's the number of new patients and here's how many had surgery. And so you can see a percentage, which varies dramatically in this group, at least for this date range we looked at, from in the 20% range down to 6% range. And there are different subspecialties and there are reasons for this. But what we're trying to get our arms around is how many new patients do I have to see if I want a surgery next month or in 2 months or whatever. And that time period to surgery is right here. And so you can see that some of them were getting them in about 3 months, others were 4 months. And the question is, are you doing something different in the pre-authorization process to get those surgery patients back in the door? I mean, if you've been shut down and it takes you a couple of months to get a surgical patient, dang it, you have got to figure out how to speed that process up or find those patients that were canceled or make the pre-authorization go better to help your bottom line. Back to our 82% of physicians have been, you know, bottom line's been hurt by COVID-19. And they did it, they do injections as well. So they were trying to get their arms around that. And this was relatively new to them. So these numbers are lower. But you might think about getting your arms around what is your hit rate. If it takes 3 new patients on average to get you a surgery and you want 45 surgeries next month, let's say, excuse me, you want 15 surgeries next month. Right? If you want 15 surgeries next month, you got to do 45 new patient visits because of those 45 new patient visits, only a third are going to result in surgery, and that's how you're going to fill your new patient slots. And you've got to kind of do the math and organize your template and your physician schedules accordingly. You might front load more new patient surgery or new patient appointments than you're used to make sure that next month you're going to fill those OR times or you're going to fill your procedure times or whatever it is you're trying to do. Am I making sense? I think it's data worth knowing for your practice. This is something that I did for a group in Florida. And what they wanted to know was, hey, if I render a service this week, if I bill a charge this week, how many weeks is it going to take for that to come in? So they're kind of in the down, the bottom of the pandemic, right? and trying to figure out, okay, charges are on their way back up. When are payments coming on the way back up? And so again, 2019 was our base year because we didn't have the mess. And so we said, this is a hospital-based practice. You can tell because there's no payments in week 0, in the week of the date of service. But they were trying to get their arms around, when is the money going to come back and when is the money going to come in? And as I see, we would chart it, right? We'd see the charges start to recover, and when's the lag? When's that payment lag going to come back? When can we see the money come in? This is another analysis you might think about doing for your practice to get a sense for, what's my payment lag? Is it changing over time? Is it getting worse thanks to COVID? Because we're not the only ones working from home. The payers are working from home. Is that slowing down? Some of those kind of things. This is from a group in the Pacific Northwest. And what they were doing is they started a project last year, and you can see the orange line is the AR over 120 days for patients. The blue line is the AR over 120 days for insurance. And they could see it getting worse and see it getting worse for a number of practice-related reasons. And so you can see they implemented some procedures to speed up their collection of AR and get it back to normal again. And then you see the pandemic and it's starting to spike again. You might try to get a sense for what you're looking at and what your change is. John, my friend up in Missoula, says, hey, the big ticket claims got me. You know, that's where the slowdown was. It wasn't the 99213s that got me. It was John's in urology practice. It was the surgeries that got me. And if you can get a sense for, here's where my problem is, then you can follow up and maybe a data mine, and maybe what John's doing is looking at, hey, if I'm going to work AR today, I'm going to work procedures, not just because it's more dollars, because I know they're going slower and I've got to work those faster and harder because that's where my issue is. If you can data mine and get to that, that's going to help you. Another poll from my friends at MGMA Stat. Again, if you don't do anything else, text the word Excel, like Microsoft Excel, to 33550. It's just a great way to get a sense for what's going on in healthcare. So the question is, by what percent did your ancillary volume decrease since COVID? And 55% said they had a more than 50% decrease in ancillary. That will get your attention. I mean, if your revenue model and your physician comp model and your pay the bills model is based on ancillary service, this is a big deal. And so the question is, how do we help the ancillary volume recover? Because back to the 82% of physicians that are, you know, in their compensations down, how do we help ancillary recover? This slide is not designed to be read I intentionally showed you everything we did, and I'm not trying to have you read every single column, but this is from a group in the Southeast. And what they're trying to get their arms around is, what feeds our ancillary business? So again, 2019 was our base year, no pandemic, so that was our base year. And what we did is we took all the providers, these folks happen to use Centricity too, by the way. So we go into Centricity and say, show me the providers, show me new patient visits, and kind of like hit rate, how long after the new patient visit until the ancillary service happened. And you can see they got 5 or 6 different ancillaries. I mean, they get MRIs and sleep beds and EEGs and all these different kinds of ancillary services. By provider, who's most likely to turn a new patient into an ancillary service, and who's most likely to do that quickly? And those could be 2 different providers, right? Some of them are more likely to convert a new patient into a specific ancillary service, and some are more likely to do it a week sooner and that kind of thing. Brian, you know, let me just pause. That's such a great comment that, you know, I was speaking in Oregon a couple of years ago, and we were talking about appointments and provider templates and whatever. And a guy in the back of the room raised his hand and said, hey, you know, I don't work here anymore, but I used to work for this academic university practice, and I think they had 1,000 different appointment types. And I mean, and you're trying to jam that into a schedule, and you're just killing yourself by trying to micromanage your schedule. And I worked with a neurosurgery group up in the Midwest, and, you know, they had very carefully, the doctors very carefully said, look, this is the way it's going to be. We're going to see these kind of patients here, and then I'm going to go to surgery, and then we're going to do this, and then we're going to do that. And they had it all mapped out, but that's not the way the patients were flowing. And they had all these unsold appointments because they were trying to overdo the templates and trying to be too scientific. And they needed some flexibility to fill the slots. And a filled appointment slot is better than an open slot, Kim. Absolutely. Absolutely. So the point of this slide is data mine your historical data and try to get your arms around how do we fill ancillary business. And if that means I give Dr. Smith more slots than Dr. Jones this month because I know I need this ancillary business filled and I'm way down, and I know Dr. Smith's going to fill 3-1 over Dr. Jones and she's going to fill them faster or whatever, you might do something like that to try to get your arms around how do I allocate appointments. Maybe I revamp my template. Maybe I do something. I need to get my arms around how do I fill appointment slots most productively. And this is the bottom line. If you're reducing available appointment slots because you're not double booking or because you're social distancing or because the local area is going to make you shut down or whatever it is, discover and then prioritize appointment slots that are going to lead to patient procedures, surgery, ancillary revenue, and that are going to help patients as well, right? I mean, the last thing we need to do is to increase our days to third and get harder and harder to get in and get patients that need to be seen, not able to be seen, because we're not managing our appointment slots like we should. Let me show you another idea. This is from Multi-Specialty Group. And what they did over here is they got the different specialties here and the providers. And what they're trying to say is, and you can see this is as the pandemic starts to hit, if you look at these date ranges. So what they're doing is they're saying, okay, which subspecialty is having a harder time getting patients to come in? Remember that question we asked earlier where we said, are your established patients more reluctant to come in? And a lot of you said yes, and some of you said no. And they tried to see that by subspecialty, so that if they're having a harder time filling appointment slots for this subspecialty, we're going to give those slots to this subspecialty and have these folks go virtual or whatever, because we got to fill those appointment slots. And you know, and Carrie, it is amazing how providers react differently to seeing patients and trying to juggle that. And very inflexible is, you are not the only person that's dealing with that, Carrie. You are not the only person that's dealing with that. And my suggestion to Carrie and to everybody else is provide them data. If you can say, look, here's your peer, and your peer has a no-show rate half of yours, or a peer has twice as many unsold appointments as you do, or whatever it is, and here's why, that data may help you with some of the inflexibility there. Anybody changed appointment templates due to COVID? Anybody that's willing to share another experience? This is great. If you're not in the chat, I mean, there's great information in the chat about what folks are doing and some terrific information. Thanks for sharing. Folks are starting urgent cares. Sally went to open schedules to fill things. And you know, it's Jennifer's gone 80 to 90% telehealth. And part of the trick is, you know, with open schedules or whatever, boy, keep your eyes on that, because what I don't want to do, I still want to I mean, the CPA sitting here, right? He wants to make sure that there's going to be bottom line money. And 99213s are great, 99203s are great, but dang it, I need procedures to keep the lights on. And how do, I mean, data mine that, understand what's happening as you change appointment types. You know, somebody said, hey, our appointments are getting longer due to COVID. And, you know, are you further backed up due to COVID? This is great information to try to deal with that. 82% of patients are, 82% of providers are down in revenue. Great information in the chat. Thanks for sharing this. I can't respond to them as fast as they're coming in. This is great information to think about, ideas to, we're not double booking anymore. And here's how we're trying to ramp up, and we're back to normal, and we're not back to normal. And we're trying to use advanced practitioners. These great suggestions of how to change and adapt to COVID. Let's shift gears for a second. I want to talk about productivity. Anybody allowing billing or other staff, what are you doing work from home? And what are you doing to encourage productivity from working from home? Tom says we're back to normal. Billing's home, 50% of the staff are working from home. Staff can't work from home, but they're trying to distance the office. Some aren't working from home. Here's everybody's back, 18% are from home. Lots of variation, because again, The great thing about this conference is you can't get any other way, except for, going to this, the National MGMA conference, is getting this perspective from all across the country where, a bunch of us are in hotspots, some of us are back to normal, some great perspective, because if you're in a hotspot this week, you tell me if you're going to be in a hotspot next week, right? I mean, it just keeps moving. Great information here. Let me show you a couple ideas. Again, prior history was our benchmark here. And what this group was is they allowed people to work from home. And then what they did, you can see when work from home started where they shaded it. And what they tried to do is get a perspective of how many tickets were being worked per week. And this was kind of where we started with kind of a basic thing. And then what we did is we data mined their practice management system, grabbed the data out of SQL, threw it in pivot tables in Excel. Then what they did is these are slicers and these are timelines. So a slicer lets you choose which provider this is staff, which billing staff, which team member you want to see. And then you can drag this timeline to adjust your pivot table to see what date range you want to see. And even by hours of the day, they can see, all right, this is when the charges went in, they didn't enter a lot of payments, and this is when they did the correspondence notes. And what they're trying to do is get some good data to get their arms around, are we as productive working from home? There was a Monday session about gamification, a big group in San Diego that was trying to grab some of this data and made a game out of it. And so, more of the carrot than the stick, right? To try to grab this data and then say, are we as productive working from home as we used to be when we were working in the office, right? And I think part of it is that they can share this information, kind of like the gamification people in San Diego did. They'd share this and publicize it so you could see, hey, here's where I am versus my peers, and trying to get your arms around, has productivity changed? The good news is you've got historical productivity data in your practice management system. And every time you go to your PM system or your EMR, you've got to log in, and that login, it tracks who entered this claim or who set this appointment or who did this pre-authorization or whatever it is. And if you can grab that and make sure you're as productive now as you were then. I mean, the last thing we need is have appointments to go down and that whole revenue stream to slow down. And then we're not working the claims as much, or we're not billing the claims as fast, or something on our end that we can control is slow. And we've got to manage the productivity side of this as well. And Whitney, great comment about last minute staff out due to, there's COVID at school, or there's COVID at home, or we have to quarantine, or my kids have to quarantine, or whatever. I've talked to groups that are trying to cross train and say, is with all of the other uncertainty, part of the productivity problem is the whole quarantine thing. And is my school district changed 3 or 4 times, in the first 2 months of whether or not you're going and how often you're going, all that kind of thing. With all that uncertainty, the ability to cross train and help pick up the pieces of the revenue stream is going to be huge. I was talking to a group in the last week that 3 of their schedulers were out with COVID. I mean, it kills the very front of your revenue cycle, and the whole thing goes south from there. And the ability to cross train. And Brian, our biggest struggle right now is staff out for COVID isolation or whatever. And it's a big deal. And anybody with any suggestions in the chat window of how to, I mean, now's kind of the wrong time to prepare and cross train, right? But what can we do in the middle of this, especially since we're not out of the woods yet? Any ideas on cross train or how having to deal with staff being out due to COVID? And Tom says cross train is absolutely necessary. Brian says, man, our housekeeping's out with COVID. Everybody's out with COVID. We taught our MA. You know what? That's a good suggestion, is if we can do some kind of work groups. Sometimes the work is, kind of set to, you open up your practice management and here's your work list. And if I'm out, nobody sees that work list. And there are some ways to do teams as opposed to one staff so that we can help cover for these productivity-based issues as COVID continues to impact our practices. Anybody do anything differently to look at remote employees' productivity as a result of COVID-19? One of the groups I was talking to last week said, well, our problem is if charges are down 30%, then charge entry is also going to be down 30%. So you've kind of got to factor that into your conversation about how productive we are. But what you don't want to do is have charges be down 30% and have charge entry down 50%, right? I mean, we've got to get our arms around that. Courtney, good. Cross training's not as formal anymore. We do a lot on the fly. Deborah's starting audits of staff work to make sure that as we cross train, whatever, boy, we're still doing, our quality and our charge entry is still the same. And, and I think part of it, you might want to throw some of this on your dashboard. I mean, part of the dashboards are based on physician productivity, right? And how many work RVUs and how many visits and how many new patients and that kind of thing. You may want to think about throwing some of these kind of metrics onto your dashboard as well to say, what does my revenue cycle look like? Do I have more denials? Is it taking me longer to work denials? Is my charge entry taking longer? Those lag days, some of those kind of things. Monica's doing daily morning huddles where we say, all right, where's the fire and who do we need to train and here do we need to allocate work and can you take this off of this list to get stuff sent in and that kind of thing. Yeah, great suggestions. This is the stat polls dates down here. So this is a June 9th poll that said, have you started to recover some of your COVID-19 volume? And 87% said they had, and about half said, we're about 75% of the way back, at least in June. You tell me what this winter is going to bring. This is the next stat poll that I think is interesting. So this is June 23. So a lot of the country is kind of coming out of that first wave now. 52% of healthcare leaders report that we've got a long-term recovery plan to recover from COVID-19. My question for this group is, what's your COVID-19 recovery plan? What are you going to do differently? What are you going to do differently as a result of this session? What's your COVID-19 recovery plan? That's the question I want to ask next, please. Bill says we're going to do more telehealth. If I remember right, Bill, you're in OB, if I remember that right. So we're going to do more telehealth. Cindy, absolutely. More attention to staff mental health. So Cindy's up in Alaska. Absolutely. That's, I mean, the whole burnout thing. And it's, I think we used to talk more about physician burnout. Is there a staff-wide component to that Cindy brings back? Trish says it's not going to be the same. And so we've got to focus on the change we met to meet patient needs. Telehealth is going to keep going. Christina says we're going to change our dashboards, and Deborah says we're going to go more weekly metrics. If you can't see these, again, minimize. Zoom wants to go full screen. Don't go full screen. Get out of full screen, and you can see some great ideas. I don't know, Leo and Craig, if there's a way to get a printout of this chat, because there's terrific ideas in here. Just the opportunity to talk and really, and I want to go to San Diego next year. I'm looking forward to annual conference. I'm looking forward to live. I'm looking forward to a lot of things. But one of the advantages of virtual is that, if I was trying to go around the room and ask questions, number one, we'd have a hard time getting this many people in the room. Number two, we couldn't have this much commentary going on. So if we can get a printout of this, that would be terrific, because they're great at it. Oh, look at this. Go, Leo. There's Ed at mgma.com will do chat transcripts. Way to go, Leo. That would be great, because I think there's a tremendous amount of good information in here. So COVID-19 recovery plan. Couple of thoughts. I think the ability to work with telehealth and to spread that load, that may be a big change for you. That part of your COVID-19 recovery plan may be, hey, we're going to keep telehealth. The great question is how many payers are going to keep telehealth as a reimbursable service, but that may be a piece of it. I think automating dashboards is a big part of it. If you can automate and do those dashboards more often and get folks used to looking at the right metrics, is going to be a big deal. I think thinking harder about how I allocate appointments and how do I make sure that my appointments, the slots that are on the template, are as best used as possible. And I think in the old days, that conversation went straight to no-shows and how do we reduce no-shows and make sure that the slots are filled. And that's still true. But I think part of it now is, how do I make sure that the slots that are on the template are filled optimally? And do I change my appointment templates to do that? or if I'm opening it wide or letting people schedule, online or whatever, how do I make sure that I'm seeing the patients I need to see to drive surgeries or procedures or ancillary or that kind of thing? And I think that hit rate slide that we looked at earlier, if I can get my arms around hit rate, and why is my hit rate so variable between providers? Is it because I'm seeing a different kind of patient, or I'm seeing more, Medicare patients, so I don't have to deal with the pre-authorization hassles that Blue Cross or Cigna or Aetna makes me go through? I think there's some of that, but some of that is processes and procedures and workflows that some parts of the team are doing that some parts aren't, that if we change to do it, we could, our hit rate would go up, or we would be more able to see surgeries faster or that kind of thing. Tammy, thank you. I hope it was helpful for you. And are we gonna downsize your rented space, Dan? That's a great question there. Christina, thanks for the kind comment. I hope what makes this, if this has been the best session for you, it's because of participation. It's because of participation. And I think the ability to participate is huge, to be able to interact back and forth and do this kind of thing. Maybe Craig and Leo, what we ought to do is do some of this on a webinar basis and do, a monthly webinar where we throw up a couple of slides and throw up a couple of ideas what people around the country are doing and adjust the presentation accordingly. So my quote, my takeaway from this is, dang it, try this at home. I don't know what piece of this you want to try at home, but try this at home. Something from this presentation for your practice is, for smaller practices is 5 figures, for bigger practices is 6 figures. To get better information and to act on better information and to get your arms around your data to do this. That's my website, moresolutionsinc.com. A lot of you know that I do free Excel videos on how to use Excel in a medical practice, and there's 500 of those on this website. But there's also weekly podcasts with ideas like this every week of what I'm doing for folks. Get your IT team to do this. Get your IT team to do that, and try to give you a sense for what's going on. Craig, you probably want to jump in and join here. Any other questions? Thanks for the kind words, Cindy. Sandy, thank you. Brian, thank you. Any other questions or things we ought to talk? The weekly podcast, Trish, you can do it off my website that's there, moresolutionsinc.com. You follow me. I'm on LinkedIn. I'm on Twitter. Every time I do a podcast, it's Pivot Table Guy. That's where you'll find me. Lots of here's what I'm doing this week. Here's what folks are doing to respond to the podcast this week. Kind of like MGMA stat. Here's what's going on this week. Think about it. Thanks, Greg. Greg's up in Portland. Thanks, Christina. Thanks, everybody. I think where I want to leave it is kind of where I started, where I would leave them all. I can get away with wearing an Aloha shirt when I present or visit your practice, because we can pull data like this out here. And if you can pull data like this for your practice and make data-based decisions in your practice, we're darn near whatever you want to the office of telehealth or otherwise, because you're using data to make decisions. I hope it was helpful for you. Thanks for joining me in my session today.
Yeah, it was really fun sitting watching all of you interact. This is really what it's all about. I think Nate made a great point that we love to be face to face, and we want to do that as soon as possible. But we've got to recognize this has been really cool. I think hundreds of chats. So thank you all for attending. Thank you, Nate, as always. Hopefully we will see you in the spring, one way or the other, for our spring conferences. And, I just want to say, I hope you guys are having a great conference. We have a solution center that we'd love for you to be a part of and go visit our valued sponsors. We are giving away the trail map prizes at 2:45 Eastern time. So please attend that. Hopefully you'll win some great prizes there. This afternoon, to cap it off, we've got Dr. Wendy Sue Swanson talking about the patient. So hope to see all of you there. Thanks, Nate. As always.
Thanks, Greg. Thanks, everybody.
Thank you. See you at the next session, everybody. Thank you.